Professor Randall. Sharma Wallace here. Okay, so this will be my final assessment, and I am sorry to see you go. We'll surely miss you. And if you have any questions or if you have any more concerns, I am going to email you. All right, so I'm going to try and see if I can make this video into the shortest one possible, because I heard that you have like 20 minutes, 25. I don't know how they get it to be that short, and I end up having 40 minutes. It's ridiculous. But anyways, I'm going to start with the assessment of the cardiovascular system. So my patient is not available. He's on call, so he keeps coming in and going out, and that's why I've been waiting up till now to do it. So I just went ahead and practice on my own, and then I'm here trying to shoot the video. So I'm going to start identifying the landmarks. So we have the suprasternal notch, the angle of Louis where it dips right here, and then across that is the second rib, and then the second intercostal space. So for inspection of signs for cardiovascular stress, chest pain, dyspnea, orthopnea, cough and fatigue, edema or nocturia, we don't really need to, like you said, touch the patient. We just need to look at them while they're breathing and out and see what is going on, if they're having any heaves or if their breathing is labored. You know, we can just observe that, or have them take a deep breath and cough to see if anything is going on. So to inspect the neck for the JVD, for this, of course, we'll be lying down angle 30 to 40 degrees on the examination table. And of course, we make sure not to put any stress on the neck and observe the vein across the neck here. And we should be able to identify the JVD pretty easily and inspect it. You know, we'll be able to see it pausing on both sides. So the next is going to be the hepatojugular reflux. Of course, we are still assuming that we are on a 30 to 45 degrees angle, and this one, it's really simple and straightforward. Here we need to, because the liver is a highly vascular organ, we're pushing at this is my right hand side, we push the liver in for 10 seconds and observe what happens to the jugular vein. So if we do that, we should notice that there will be a high response, like the vein would pop more when we hold the right lower quadrant, the liver area, down for 10 seconds. We should observe some movement at the hepatojugular area. That's a reflux. So there should be a small rise there. And then for the apical impulse size, we should just inspect. First, we're going to just wait and watch our patient. So and make sure there is no heave or lift while they are lying down, and this will be observing this at the fourth, fifth intercostal space. So we'll have them lie down and then observe and make sure there is no heave or lift while they are breathing in and breathing out. So for the palpate, for us to palpate the apical pulse, we're going to show the location and the size and this will be using just one finger, and the same for between 4th and 5th intercostal space, right at the chest, where the chest shape, if it's a man, stops right here. We can use just a finger to palpate that area, and the size should be small and normal, short, and it should be like half a systole of amplitude. We should just feel like about half a systole here. So just use a finger and palpate right between the 4th and the 5th intercostal space, and we should be able to check the size. If it's long, then that's not good. When we feel the pulse, it should be short, and we should feel a normal pulse. Anything apart from that will be considered abnormal. So for us to palpate over the precordial area for trills using at the palm surface of our hand. This is my left side. We'll palpate with the palm of our hand, so we'll place it under the chest here, and then we'll palpate one here, checking if everything is normal and there's no tenderness. Of course, we'll ask our patient if there's any tenderness or pain, and then we'll move over here, which is like the middle of our chest, and then up here, which for us to do this, it covers the whole area. So and it may be weird because I'm doing it myself, but it's supposed to go from here and then here and then here. Okay, that concludes our palpation, and then we can identify the areas of the areas that are the loudest for auscultation for our heart, which is I'm trying to check the area between the S1 and the S2, and for this one, I'm not going to put it in my ear. I'm just going to show what I'm doing with the stethoscope. We're going to be using the diaphragm for palpation, and this is on. I'm going to use the diaphragm for the palpation, and I'm going to start with the APETM. That is the 5 kind of landmarks. So we'll start with aortic, pulmonic, Erb's point, tricuspid area, and then mitral. So angle of Louis, the suprasternal notch, angle of Louis when it dips, and then across the right hand side, here is our aortic area. This is where we're going to auscultate for our first landmark, and then we're going to listen to a full breath cycle, and then directly across is where we'll find our pulmonic area, and we're going to also go ahead and listen for a full cycle. And while we're doing this, of course, we're listening for any adventitious sound that we might hear, wheezing or coughing or any of those or murmurs. And then for Erb's point is just down 1 intercostal space below the pulmonic area. We're going to also go ahead and listen to this with full breath cycle. And then for tricuspid area, it's going to be between the 4th and the 5th, which is just at the edge of where your chest stops. Well, for a lady, it's going to be like where the boobs stop. For a man, it's going to be where the pec stop, just at the edge between the 4th and the 5th intercostal space. This is going to be the tricuspid area. I'm going to go ahead and listen to it for a full breath sound, noting any discrepancies or any adventitious sounds we hear here. We do hear around this area. And then the last one is going to be the mitral area, which is if you move left, just left of the tricuspid area. Also going to do the same here. after this, then we're going to go ahead and then move over to listen to the S1 apex and S2 base. So for this, the S1, I noted that this one is going to be I always get confused here a little bit. So S1 is the systole. So it's going to be between tricuspid and mitral, and we, like you explained, we kind of have to find it between the mitral and the tricuspid here, and then the mitral is going to be somewhere between. The day I performed it on my patient, I was able to find it. It was difficult, but I was able to find it. And then we should be able to listen to it fully and hear where it's loudest here. And then for the S2, which is the aortic, the distal, it's right at the apex, which is the right hand side across the aortic area. So we should be able to also listen to that and compare the two, which one is louder. And after noting that, we're going to go ahead and auscultate for the carotid artery for Bruce using the bell. This time I'm going to flip our stethoscope to the bell side because the Bruce sound is louder and harsher. So this is how we're going to hear that correctly. And here you mentioned we should do the angle of the jaw, the mid-cervical, and the base of the neck. I actually had to consult with my study buddy that he linked me up with, and we figured out that it's going to be like a cervical chain, which the angle of the jaw is going to be where the jaw and your neck meet. They're going to also go ahead and auscultate that area and check for brood and listen to it for a full 60 seconds. And then the mid cervicular area is going to just be the middle of your neck here, following the cervical chain, while the base of the neck is going to be where the neck and just top of the clavicle here meets. So you're going to do the first, second, and third and listen to it for a full breath cycle, 60 seconds, and note any advantageous sound you might hear. Also, for the number 9, S1, where S1 coincides with the carotid artery, I'm going to go over that one again. So while you're listening to the S1, down here, we're going to place our finger, whether 1 or 2, our carotid artery here, and make sure that they both beat at the same time. They're supposed to correspond in timing and pulsation. So number 12, of course, while we're doing this, we're going to listen for any tachycardia, normal sinus rhythm, and murmurs, and note any other sounds we hear. So for the assessment of the respiratory system, here first we're going to inspect for signs of respiratory distress, nasal flailing, retractions, or use of accessory muscles. So we're just going to have our patient lie down and we're going to inspect to see if he has difficulty maybe in speaking, if the nose are flaring while he's breathing. All this is abnormal and we would note that. And then we're also going to check the shape and the symmetry of the chest wall, make sure that he has nice shape, not warped, and then have him taking a deep breath and make sure that the chest is rising and falling symmetrically. And then we're going to go ahead and palpate the chest, which we can use 2 fingers or 4, but 2 is better, and then we'll palpate like in circles to feel if we have any like nodules or tenderness or lesions. And of course, while we're doing this, we'll ask our patient if they have any pain or if they feel any tenderness. And then we're going to palpate for tactile fremitus, which is we can use like at the edge of our palm here, And what we do is we have our patient lying down in same position or sitting if we're trying to, for the video sake, and then put your hands like here and ask them to say 99. I say 99. I can feel 99, my chest, my hand vibrating, and then all across the chest area, which is the anterior. We're dealing with the frontal area, anterior area for now. So, excuse me, we're going to do this in 6 to 8 places, and then we're going to go ahead and also palpate for symmetric expansion. I've mentioned that before. And let's see. We're going to also palpate for symmetric from expansion, and have him take a deep breath and observe how the chest expands and contracts. So we're going to also percuss for long resonance comparing sounds bilaterally, which in the full video we did before, we started from bronchial sounds, then broncho, and then vesicular. So basically from bronchial sound, we're going to for percussing, just percussing, we're going to start that auscultation. For percussing first, we're going to, of course, percuss with our fingers. It's going to be over and down method. So if we start here, we percuss here, move over to the other side, then down, and then move over to this side. So we're going to go ahead and do this at least 6 to 8 places and percuss all around, and we're listening for the dullness, resonance or hyperresonance sound while we're doing this. So after percussing, we go ahead for auscultating, and while we auscultate, like I mentioned before, for the frontal anterior chest, we're going to do the broncho and vesicular, and also we're going to listen to the entire lung field. For the broncho, we start around here, and then of course we do it across the field, and then move over to the rest of the chest area. So this we're going to do as well over and down method. We go ahead and listen for a full breath sound and auscultate, and do the same to the other side, then move down and also go over to the other side. So it's going to be the over and down movement, and we're going to do this for 10 to 12 places, and note any adventitious sound we might hear along the way, which can be whizzing or crackles or any of that. And then while we finish the anterior side, we're going to move over to the posterior side, which is the back, and we have more space to work with. We're also going to check for muscle pallor, sinuses, difficulty in speaking, and we'll ask the patient to breathe in and breathe out. And then we inspect the shape and the symmetry of the chest wall to just make sure that everything is the correct size and shape while he breathes in and breathes out. And then we're going to palpate for tighter fremitus, which we use our edge of the palm to palpate across the whole back. So it's going to be the same thing we did at the front. Put your hands and then ask them to repeat 99, and then move it across the back. It has to be symmetric so that you can compare what's happening on the right hand side with what's happening on the left hand side. And then after palpating for tactile fremitus We're going to also check for the symmetric expansion, have them breathe in and breathe out and check. And then we're going to percuss for resonance sound, which is what we did in the front. And we're also going to go ahead and palpate across, over and across and down, just like we did in front. We'll not palpate, percuss. We're going to percuss, start from the just above the shoulder here. We don't have the broncho at the back, so we're just going to start with the we don't have the bronchial at the back. We're just going to start with the broncho, and then the vesicular, which is the rest of the back. So we're going to start with percussing from top of the shoulder here, then across, and then down and across. So it's going to be that movement. So over and across, down, over and across, down, just like that. And then we're going to do this in 14 to 18 places. And then after that, we're going to auscultate. And here we're listening for any adventitious sounds. And of course, we're going to start at the with the bronchovesicular sound and listen for a full breath sound, and then move over and then under, and then move over and then under. We're going to listen for any abnormal sounds you might hear, and we do this to 14 to 18 places because we have larger chest back area to work with rather. So after we do this, we're going to also do a vocal sound test, bronchophony. And for bronchophony, these are the special tests to perform. This we kind of anywhere across the lung area would auscultate and ask the patient to say 99. For the bronchophony, it will be muffled. You're not supposed to hear it. I know if I do it right now and say it, I won't hear anything, but I tried it when I did it with my patient, and I wasn't able to hear anything. I just heard like vibration, kind of muffled sound, and that's good. So that's what we want to hear. Then for the other two, the egophony, we ask our patient to say E while we are listening with our diaphragm. And for this, when they say E, we're supposed to hear R, not E or muffled. It's supposed to translate like an R. And then for the pectoriloquy, we're going to have them whisper 1, 2, 3, and it's supposed to come off as muffled vibration, just like the first one. We're not supposed to hear the words, we're not supposed to hear anything else except like it will be a little bit muffled and we won't be able to make out exactly what was said. So, of course, while we're doing all this, we're listening for any adventitious sound. And then we're going to move over to the peripheral vascular system. And for this cusp, we're going to check our patient for the, of course, we'll have a baseline color. My patient usually is pink. So we check for color, any ulceration or swelling, or pitting edemas or scars, and make sure that there is nothing we are missing while we're doing the inspection, since inspection involves just you watching your patient. And after this, we're going to move over to temperature. You just kind of use the back of your hand and touch all over the patient and make sure that they're not too warm or too hot or too cold, which could mean maybe an infection.